Hey everybody and welcome. It's Craig from the University of Applied Research and Development, and it is our honour to have Paul Mikita with us. He's the lead emergency preparedness specialist at Robert Wood Johnson University Hospital. Hey Paul.
How you doing?
So good to have you with us.
Thanks for having me.
So we've done a couple of talks before, and one that was really interesting was where you talked about setting up an incident command center, which I've had some really great feedback from, particularly from our students in the Bachelor of Emergency Management. So it's really valuable, and I'm delighted that as a senior emergency manager such as yourself, with a lot of experience and originally boots on the ground.
I have experience. I'm not senior.
Well, let's talk about your incident command center and what's happened in the last year, because obviously it's been a busy time, Paul, and you've made time to share with our students.
Yeah, we've definitely been tested over the course of the last year. There was this thing called COVID. I'm not sure if anybody's heard of it, but it kind of hit our region back in March of last year. Prior to that, I think our longest hospital command center activation was a matter of 2 days, maybe 3 days for a tropical storm or weather event. This one saw us activated from, I believe it was like March 4th straight through to like May 22nd. So that was the longest wow. activation that anybody that's in the hospital ever remembers. It was actually kind of interesting because it was long enough that we were actually able to evolve the incident command structure as the event went along. That whole after action report improvement project type process that we used, granted we still had them, but a lot of the ones that were command center based actually were resolved by the time we identified them in the report, because it was long enough that we actually progressed through the process.
So can you give us an example of some of those things that have changed over this period of time?
A couple of things that kind of came up was the better integration of technology. I believe when I did my presentation with you, we were a couple of laptops, a couple of office files, but sharing of those files was rather difficult, if not, not possible, because of the setup that we had. So subsequent to our little talk, we actually went through to our information technologies, got each of the laptops to sign on as a different user account. And what that actually allowed us to do during COVID was actually start sharing files. So, for example, now we had a tracking board for call taking and a tracking board for resource requests. Historically, they had to be two separate forms, and then I had to call you to say, hey, I just got this request. We were actually able to leverage the strength of MS Office, or Microsoft Office, and actually set up a sharing component so that you and I can both be in the same file, and any changes I made would automatically update on your screen. So, what we found with that, though, is as we're progressing, it still requires us to be on site. So a couple of things that we're looking at now is taking our technology involvement to the next level and looking at a web-based platform that would allow specifically our administrators on duty, who serve as our incident commanders, to be able to jump into an incident ahead of what they do now, which is the requirement of travel time.
Right. What are some of the things that you would put in place to enable that to happen then with that implementation?
Well, a lot of that is identifying a platform, but what that is making sure it jives and coincides with the program that we have established. One of the downsides I found in doing my research for a lot of these is they're very black and white, for lack of a better phrase. They're very structured and very defined, and they're well defined for a field setting, not necessarily for a hospital or a healthcare setting. Right. So the trick is trying to find something that has the end user flexibility enough that allows us the ability to modify the job descriptions or even a title to be more in line with what healthcare or our hospital has developed as a incident management process. Not necessarily an incident command process, but incident management process. Then what that is going to, I'm already working on it, or ahead of the time, plans for education, identifying who we're going to have to put in play for the different areas. Obviously, anybody who's going to serve in that incident command role or a functional area role is going to have some sort of training in it. And then it's just, on the back end of that too is also the amount of work that's going to go into it. I've said for years that for any task there is a set amount of work that has to go into it. If as the developer I want it easy on the end user, there's more work on my end to make sure all the background stuff is squared away so that all they have to do is click a button and the program does what I want it to do. If I can care less about that, it's going to be more work on the end user side, which is going to be more education. So now once we kind of settle on a platform, the game plan is to try to get all this stuff squared away.
We were talking before we went live that the members of your team are from other departments all around the hospital, and so this is not
Correct.
their major gig doing
Correct.
emergency management.
And that right there is the other component of this. Whereas my colleagues in the field who do emergency management for a county or something else, they have a team that all they do is emergency management. Now you may be a hazmat person, but your primary role is emergency management. Here in the hospital, because we don't have that structure, 99.99999% of my staff that would staff the command center during an activation are directors or leadership from a clinical or a non-clinical department. So anything that's put into play has to be easy enough or simple enough, for lack of a better phrase, that they can transition in their head to the new role, which may be a role that they may have done last week if they were on call, or it could have been a role that they did a year and a half ago, depending on how our activations and our processes go. So it's with that is also the aspect of the education is unique as well, because how people think on a clinical setting is not how they think in a non-clinical setting,
Right.
and neither of those are necessarily applicable to how they need to think during an emergency.
So because you have people that are not specialists in emergency management and they're coming from other areas, does that change the way that you do your incident command system or process?
Not necessarily. It does change how we set things up. One of the things that kind of came, once again, is a development partially out of COVID, partially out of other activations, is in most command centers, what you would see is people wearing the vests we all know about. Incident commander, operations section chief, planning, logistics, so on and so forth. We still have those vests, but we've kind of pushed them to the side. And in turn, what we've done is we've developed place card holders. So it's an 8.5 by 11 piece of paper, and they're color coded by function. Incident command is green, operations is orange, logistics is yellow, so on and so forth. And on both sides of those, it has what the role is. But on the side that's facing the person in that role, we actually have on there a section, a little bullet point section of what they're responsible for. So that
Right.
one form kind of serves as a job action sheet, and we basically wrote it out in layman's terms. So it's like so it'll sit there and say, the role of the incident commander is to work to developing the objectives. But underneath that, we have in parentheses the what needs to be done. So we kind of set it up so that the job action sheet itself is the translation between the regular everyday duties and what the command center is. And so far, we've had some pretty good success with people making that transition easier with a good chunk of the staff.
Is your team physically located in one place?
As part of the command center compartment, yes. I mean, well, the core group is. We do have personnel that are in different locations. Logistics is usually down in the storeroom. Which is part of this push that we're now having towards going towards a platform that people can access from anywhere.
Right.
We've been able to integrate GoToMeeting, which is our system, which is the platform that our system chose to go with as a result of COVID. Integrate that as part of our incident command role. So usually what we'll do is we have a meeting room that we set up, and we just leave that meeting room open for the entirety of the incident. And we'll schedule certain times that, logistics, I need you to be in this meeting at, 1:15. So they can be wherever they want. They can just jump into the meeting. We can do our quick little synopsis, and then we can kind of move things forward. Done for two reasons. One, obviously social distancing as a result of the pandemic, but also what we found is, and as most of us probably will find, the more people you put in a small location, the noisier it gets and the harder it is to get things accomplished. So if we can try to do things from a distance, we're finding that to be beneficial. We're just looking for something that's going to give more feedback, more real-time feedback, as opposed to waiting till 1:15 to hear from you.
Right. Is your hospital in the process of delivering vaccinations, and are you involved in that?
Yes, we are. We started doing vaccinations for our staff back in December. I am presently not involved in it, but I was involved in some aspects of the planning to set up. We had not had a mass vaccination plan. I'm sure most of us haven't had a mass vaccination plan for any of our processes. But as part of our management, I don't even want to say philosophy, but part of management lessons learned, we figured that we'd look to see, is there anything that we presently have or currently have that we can apply to, the vaccination process. With that, we actually wound up modifying our closed point of distribution plan. So we actually have a plan where, if there was a biological attack, i.e. anthrax or something like that, that we would be able to distribute medications that come to us from our county to our staff as a closed point of distribution for antibiotics. Took some finagling, took some numbers wrangling, but we were actually able to pretty successfully convert that to a mass vaccination plan that kind of became a central component of what the hospital wound up doing. Starting in January or so, January, early February, we actually, at the request of our State Department of Health, actually opened it up as a community pod, community vaccination pod, which became even more of a challenge because now, before it was all staff. If something happened, it was whatever it was. But now we're trying to coordinate things with the community and messaging and route to travel inside the hospital, and just transport. I mean, I remember back in February, the majority of the people that were coming in for vaccinations were in their 80s and 90s, and most of them were in wheelchairs, and they weren't allowed to come with anybody else. So we now had to figure out how to, because of social distancing. So we in turn had to figure out how to dedicate staff just to transport people from the main lobby to the vaccination clinic. It was definitely interesting.
I was speaking with Dr. Quinton, who's on our faculty. He's an MD in Guernsey in the UK, and he was talking about managing the process of deploying the vaccinations and the impact that it has on workload across the entire hospital. If people need to do their own jobs, but there's also this workload involved, and managing that has become the most important issue for him as the leader. Yeah.
We actually our vaccination clinic is staffed by volunteers. So what they've done is they've actually taken a lot of our directors are filling that role, or people in those types of positions. But even at that point in time, they'll be at the clinic for 4 or 6 hours, doing their part, but their workload underneath them for the regular workload doesn't change. So now you have people that are responsible for multiple departments, basically off the radar for a couple of hours. It definitely trickles down to them having to have trust in the staff and their leadership underneath them to manage the things while they're doing this, for lack of a better phrase, really important function.
I wanted to ask about, after this year and this being a very long incident, and people responding, what are some of the areas that you think could deserve some research and attention?
In reality, and this is just me being, what's what I'm looking for, preferential, healthcare response, and not just acute care response, just healthcare in general. I've learned over the years I've been doing this, both on the EMS side as well as the acute care side, both in the ED and as a nurse, and now this position, that not so much research, and probably research as to how to best do it, but all of these functions, all of these processes are very disjointed. There's what happens at one level, it impacts all the other levels as a two-way street, and people really don't think about it. What happened, how EMS packages a patient during an MCI and where they choose to transport that patient to has an impact on how that patient's managed in the hospital. If they're sending the 50th patient to a hospital that has 49 others, and there's another hospital down the street that has 10. How those patients at that first hospital are going to be managed is markedly different than how they're going to be managed at their other hospital. Just like nursing homes. How hospitals discharge patients to nursing homes is as important as the nursing homes being there to help facilitate the throughput, to help with the patient management, to help free up the ED space, so that EMS has a place to drop the patient off. Then that whole coordination definitely is an area that probably should be looked at, because it just keeps falling apart, for lack of a better phrase.
Right. Is that one large organization which has all of those parts inside of it, or is it separate organizations?
In the United States, they started putting together, a couple of years ago, they put together these healthcare coalitions, which has representatives of each of these sections. They tend to be a little bit more, for lack of successful, if that's actually even the right word, in the more rural communities where there's a heavier hit on that interdependence. But as with most things, you sometimes hit the aspect of, you and I may be a hospital working in the same county, but my hospital is a different healthcare system than your hospital. What becomes the incentive for us to kind of work together throughout the whole process? So in some aspects they do exist. In other aspects, in a lot of aspects they do exist. In other aspects, some are more efficient than others, depending on how it goes and what goes into the back end of it.
Yeah, that sounds like a really important point. What do you think would solve that? Is it a communication issue? Is it a systems issue? What is it?
That's the $1 million question issue. It is. I mean, it's part of its, as we've spoken about in other sessions, the mindset for emergency management is different than the mindset for every routine everyday business. And I hate to say it, but in a lot of cases, they're mutually exclusive. You can sit there and have all these regulations come down saying that your facility has to be prepared for A, B, and C, but they become unfunded mandates.
Right.
So what you wind up with is institutions at all levels, healthcare and private and public and whatever, doing things to check the box. Now, and so you have these regulations which are truly designed as a foundation, as a benchmark that you start from, not the roof that you end at. Not truly being realized because there's the business of emergency management is not necessarily good business.
Right.
To make sense.
Yeah. Paul, the last time that we spoke, or the time before, I asked you if someone wanted to get into your line of business and follow you in your career, what would you suggest? Given hindsight in the last year as well, what would you suggest that people do with some learning experiences to prepare themselves?
As with most things, a lot of these things are very, very region specific. I tend to find I have a lot of colleagues who do healthcare emergency management, and they are EMS based. They're phenomenal when it comes to managing an incident in the field, but it's not necessarily the same management style that you would see inside a hospital. Different objectives, different priorities, different tasks associated with those priorities. Anybody going into a healthcare type setting, I would definitely recommend getting into that sector first, making and learning it. I often tell people I've been doing EMS 26 years. I've been at the hospital here going on 21. I've been around the block enough to know how the pieces interconnect, and more importantly, how they should interconnect, which allows me to kind of steer conversations and develop guidance that's operational and can actually be used by my colleagues and coworkers. Even in the event that I'm not present to help manage the emergency. So I would definitely say, get into the field first as a non-emergency role, and then kind of develop those connections to move yourself into something that's more defined for what you're looking for.
Yeah, that's really valuable. Paul, any final words for our watchers, our listeners, and particularly our students that are doing our Bachelor of Emergency Management?
I mean, obviously you know how to get a hold of me if you have any questions. So I mean, by all means, you know where to find me.
Awesome. Well, we'll definitely put your link to your LinkedIn profile
That's
and
fine.
with the recording of this. Thank you very much, Paul. Thank you for your time and your expertise, and your experience is really valuable for us. So thank you so much.
Once again, thanks for having me.